Boa tarde a todos e a todas. Hoje, na nossa reunião semanal do Centro de Pesquisa Clínica, nós estamos recebendo a visita de pesquisadoras da University of Birmingham, a original, UK, not Alabama, the original, and e nós estamos com duas professoras, Peimani Abbey e professora Rachel Jordan. E temos a Gisele, que é representante brasileira na University of Birmingham. Nós temos trabalhado já há um bom tempo com a Universidade de Birmingham, com alguns projetos, no caso de fibrilação atrial, e agora nós vamos iniciar um em relação à doença pulmonar obstrutiva crônica. Então, é com muito prazer que eu apresento a vocês a professora Rachel Jordan, da University of Birmingham, que irá apresentar um tema extremamente interessante, que é construindo a pesquisa de doenças pulmonares em todo o mundo. Rachel, it's a pleasure to receive you here, to be as the chairman of your lecture, and I think that you have the time enough to explain everything, and after this, the audience, you ask something by the chat or personally.
Okay.
Okay? Please, go ahead.
Thank you very much. Okay, good afternoon, everyone. Thank you very much, Professor Lotufo, for introducing me. I'm here today with my co-lead for our various projects, Professor Peimani, who's also in the audience. So you can always ask her questions as well. Okay, so more close. Okay. So my name is Rachel Jordan. I'm a professor of epidemiology and primary care at the University of Birmingham. I'm also the director of global engagement for one of our 5 colleges, the College of Medical and Dental Sciences. And there is one of our famous landmarks of our university called Old Joe. It's a very big clock tower, which these days doesn't tell the time properly at all, but it's very traditional landmark of the university. So I thought today that I would tell you a little bit about Birmingham and the university, and then talk about the importance of COPD across the world, so not just in the UK, but across the world. Cover some of the research that we've done in the UK and some of the research that we've done more globally, and then focus on our new project with Paulo, which is in South America, not just Brazil, but 2 other countries as well. And then if you'd like, at the end, you can ask some questions. So this is Birmingham. I'm very proud of Birmingham. I was born in Birmingham, and I've been at the university for more than 25 years, so you can tell that I really like Birmingham. Birmingham is here. This is England, and Birmingham is right in the middle, well, more or less in the middle of England. And it is, in fact, the 2nd largest city in the UK. It's nowhere near as big as Sao Paulo, but it's still one of our largest cities, around 2 million, and part of a wider area of 5 million in the West Midlands. It has a very multicultural and diverse population. In fact, I think that the white ethnicity is now 49%, so 51% of Birmingham is multicultural or multi-ethnic. Originally, it was, and it's also the youngest city in Europe with very young population. It was apparently in 1790 or something, the first manufacturing town in the world, and that's the basis of our economy. And in fact, because of that, it has lots of canals where the components and the manufacturing processes and equipment and supplies were carried around Birmingham, and we actually have more miles of canals than Venice and more public open spaces. So in fact, it is also not just industrial, it's actually very green as well. So hopefully you'll come and visit sometime. The university itself, and this is an aerial view of our university, so you can see the clock tower and the original buildings, and then the old hospital site up there, and somewhere where our building is around about there, I think. Difficult to tell. But it was founded in 1900 by Joseph Chamberlain as one of the first civic universities of the big cities in England. We share a rank which is very similar to USP. In fact, we're 84th in the world, and I think USP is 85th on the QS rankings. So we're very, very similar to you. We have more than 38,000 students from a wide variety of countries around the world. And one of our main focus is that we are a very research-intensive university. And we have a wide range of alumni across the world. Okay, so that's Birmingham. And now I really want to talk about COPD. Now, COPD, which you probably all know, it stands for chronic obstructive pulmonary disease. And it's a disease of the lungs, a chronic disease of the lungs. First of all, how is it defined? Well, if you went to the GOLD website, you find some very nice reports and definitions, which is they're the leading committee in the world, which influence the care and management of COPD. So that gives you plenty of useful reference documents if you're interested. But COPD is defined as a heterogeneous lung condition. It's characterized by some chronic respiratory symptoms, so dyspnea, cough, sputum, and phlegm production. And some people have exacerbations of this as well. As they go through their lives, they have exacerbations or flare-ups of their condition. It's caused because of abnormalities in the airways and alveoli that cause this progressive airflow obstruction, often caused by cigarette smoke, and we'll talk about the risk factors in a moment. In order to diagnose COPD, the recommendation is that among people with symptoms and a history of exposures, then they need to undergo spirometry. And at the moment, this is the current standard for the forced expiratory volume in 1 second, divided by the forced vital capacity, has to be less than 0.7, and then someone can be diagnosed as having COPD in the presence of those symptoms. So why is it important? Well, actually, it's the third most common cause of death in the world. And the vast majority of those deaths are in lower and middle income countries. Interestingly, although we have around about 251 million diagnosed cases in the world, 80% of those cases are undiagnosed. And you can see here, this is some seminal work from the BOLD study, the Platino study, and other studies which have used the same protocol to evaluate the prevalence of COPD in all these countries across the world. And they vary, but you can see the proportion of diagnosed at the top and the big underdiagnosed population underneath. And ultimately, people with COPD have a progressive disablement, progressive symptoms, such that many of them have to leave work, and therefore there are high economic costs to the patients and their families, but also to health services and society. The health services, because many of them end up with repeated respiratory infections and they end up in hospital because of those exacerbations of their condition. And I looked at some data last week, and you can see that in terms of the importance of the disease in Brazil, in 1990, chronic respiratory diseases, which would be mostly COPD, these are deaths, was ranked number 11th. And now, in 2019, is up to 7th. And that's the latest data from the global burden of disease. Now, the global burden of disease is very important work in epidemiology, because it looks at a whole range of factors in terms of determining the prevalence, the disability adjusted life years, the death rate, and also some of the risk factors in different places. And here you can see that these are the risk factors. We've got smoking. So globally, this is the rank order of importance. Smoking is the most important risk factor, but ambient particulate matter pollution in the air, occupational exposures, household air pollution from people that are using solid fuels for cooking, non-optimal temperature, so extremes of temperature, high and low, secondhand smoking, etc. And then also there are other risk factors that we know about that are not in this chart. Early life development can hinder the growth of the lungs. Asthma is a risk factor, and respiratory infections, and I'll show you a bit more about that at the moment. And the middle income countries, such as many in South America, have a similar ranking, but actually there's a slightly different ordering there, but the main risk factor remains smoking. So this is just some information about smoking, that people who smoke have a greater mortality from COPD than non-smokers. It contributes about half of all COPD cases. It dramatically increases the rate of decline in the airways function. And but not all smokers will develop COPD. It really depends on a combination of genetics and the environmental exposure to COPD. Other types of tobacco are also important, as is passive smoking. Just some information on biomass fuel exposure, that if wood, animal dung, etc. are used in stove cooking inside tents or enclosed areas, they can lead to very high levels of household air pollution. And 3 billion people in the world still use biomass and in coal, which is not properly ventilated, as part of their daily cooking and heating. This is some data about air pollution. I'm not going to talk in detail, but you can see that particulate matter and so on are responsible for a much greater proportion of the attributable risk for COPD in LMICs than they are in more developed countries. And it's a dose-dependent risk with no particularly safe thresholds. And they do particularly increase the risk of exacerbations and hence visits to hospital and death rates, which are very high amongst people who've been admitted to hospital. And so it's really important that both smoking is reduced and both indoor and outdoor air pollution is reduced as well. Very important for people with chronic respiratory conditions in both the prevention and management of COPD. But another important thing, which is often not really thought about, is the importance of respiratory infections. And there are several here that we talk about, but TB, so in some areas of, say, Peru, for example, we're working with our partner in Peru, where TB is a really important risk factor, and perhaps more important in those areas than smoking. So what have we done to do research in this area? Well, much of our work has focused, in the UK, is focused around this undiagnosed population. And we first asked the question, okay, all of these people are undiagnosed. Why does this matter? Does it really matter? Why don't we just wait for them to come to their GP? Well, the thing is that people with COPD often, they present late. And they present late probably because they have other conditions that they're worried about, because most of them in our country will be smokers or ex-smokers, so they'll have other conditions as well. And not only that, there's a somewhat of a stigma involved in them being smokers. And so they may just pass it off as, they may be in denial, or they may pass this off as a smoker's cough. But at the end of the day, they turn up at their GP, but it is late. And this data actually from the CanCold study shows that it doesn't, although the people who've got a diagnosed COPD, who have more severe COPD, they have clear problems in terms of exacerbations and events that require health service intervention. But actually, those people with undiagnosed COPD, they are having exacerbations, if you ask them, and they are also being treated in hospital as well. So actually, they do cost themselves, and they do cost the health service. So maybe you might think, well, if we identify them earlier and we treat them earlier, potentially we're going to reduce those hospital admissions and the mortality. And in fact, one way that we might be able to identify them is put a screening program in place. 'And so we have explored some of the evidence for this. This is actual, we have a committee in the UK called the National Screening Committee, and this is data from their exploration of this question, which shows, and you can look at that report, but it shows a large number of different types of screening tests that there are in quite a number of different studies. And overall, there's spirometry we can use, there's questionnaires or combinations of them. We can use risk prediction algorithms, which have got particular parameters in which would suggest that someone might have COPD, and we can apply them to different types of populations and design our screening perhaps in that way. And the performance of these tests are generally reasonable, but they do vary in different settings. So potentially we have a reasonable screening test. But the work that we've done, so we have done some work around doing systematic reviews and to define those screening tests. But the work that we did in the UK, that we were funded from our National Institute for, was called the Birmingham, comes under our big program of work called the Birmingham Lung Improvement Studies. And we designed a trial to compare different ways of screening for COPD patients. It was a pragmatic cluster randomized controlled trial in 54 general practices in Birmingham and the surrounding areas over 1 year. And we recruited patients from these general practices if they were ever smokers, so smoking was a prerequisite. They were aged 40 years and above. They did not have a previous diagnosis of COPD. And we asked them to fill out a screening questionnaire and to, if they were positive on the screening questionnaire for any of our symptoms, to ask them to come to the clinic for spirometry to diagnose their COPD. Now, what we did in the intervention is we compared a targeted approach, so a systematic approach for identifying these patients with our routine care. And our routine care is generally only treat patients who, or only diagnose patients who present to their GP with symptoms. So this arm was routine care, just do as usual. This was a specific type of case finding. And we compared in that one arm 2 different things: a postal questionnaire with an opportunistic questionnaire. And these were our results. So we published this in the Lancet Respiratory Medicine in 2016. And we found that if we put in a systematic approach to identify new cases, it was 7 times more likely to find COPD cases than usual care, where there was a very low level of diagnosis. Furthermore, it was actually more cost effective. And if you compare the 2 different approaches, we found that GPs were very busy in their clinics, and that the most important thing was to send out a questionnaire to patients at home and then ask them to respond directly. So among these 2 approaches, the active case finding approach with the questionnaire sent to people's homes was more effective and more cost effective. And these were the characteristics of the people that we found. While half of them had fairly mild disease, we did have people with moderate and some with very severe disease. A third of them were still smoking, so they were eligible for smoking cessation. Over a third of them had quite severe breathlessness, and so therefore they were eligible for pulmonary rehabilitation. And finally, half of them had some quite symptomatic things which could be helped with inhaler treatment. However, it's all very well identifying them, but then what do you do? What do you do next? Is it effective then to manage them? Do they have better outcomes? So we compared the 2 groups. Later on, we did a post hoc follow-up of this study. And unfortunately, what we found was there was no difference between those who were screened and not screened in terms of their outcomes on respiratory, hospitalization, all-cause hospitalization, and mortality. So there was overall no evidence of long-term improvements. And when we explored that, we found that very many of these new patients actually had not made it onto our GP registers. And in the UK, we have a register of patients that has quite should be then subject to quite intensive treatment and follow-up. If they didn't make it onto the register, they were not going to get treatments. And actually, we found that a lot of the GPs were too busy to add patients to their register. And that was one of the main problems. And in fact, other studies have shown a similar thing. You find the patient, but the GPs are too busy to actually do anything with them. And when we asked the GPs with some qualitative research, we found that mainly that exact thing. Managing the patients who are already on the COPD register is an onerous task anyway. So going out and finding extra cases, there's a cost implication, there's a time implication, and therefore it's not going to happen. And this other quote is also from a nurse, is also about overwhelming primary care and the workload. So I think we conclude out of that, and the National Screening Committee conclude that a number of different things, but overall, because there is no current trial for long-term benefit, that actually in the UK at the moment, we do not do screening for COPD. And one of those, so the main problem is that when people are found that they're not adequately treated. And so when we do our future studies, in particular the study in this country that we're planning to do, that's a really key component of our plans. Okay, so that leads me on to what we did next. So we've done this huge, big trial in the UK, and then we started to think about, well, the UK is just one situation. We already have COPD registers. We have about a 1% prevalence of diagnosed COPD in the UK. We do have some underdiagnosis, but more than, probably 60 or 70% of patients are being adequately treated or are being managed in primary care. But the situation is not the same in other countries around the world. As I said, in overall across the world, around about 80% of cases are undiagnosed and there's no management pathway for them. So we obtained some money from our UK government, who were wanting to, from our Overseas Development Aid Fund. And we called the programme Breathe Well, which stands for Building Research Across the World in Lung Disease. And we worked very closely with the International Primary Care Respiratory Group, which is an international network of respiratory clinicians around the world with a focus on research, education and advocacy, and is in probably 55 countries around the world. So they're very keen to improve the health of our respiratory patients in primary care. This was our partnership. So I've mentioned my colleague, Professor Paymani Adab, who I work very closely with. And we worked with colleagues in China. We worked with colleagues in Georgia. We worked with colleagues in North Macedonia. And of course, we worked with colleagues in Brazil as well. And that was a partnership between USP and the ABC Medical College. And the aim of that was to develop a sustainable collaboration, to develop future research, to make sure that we're undertaking research which is locally relevant. That's important, that it's not just us that's deciding the research agenda. And with a focus around the prevention, diagnosis and management of COPD in the community setting. And we had a focus to train local doctors and local researchers in research, and to build, as I said, this platform for future collaborative research. So why did we choose these 4 countries? Well, there are quite a lot of differences, different sizes, Brazil is enormous. North Macedonia has 2 million people in total, so very small. They're all on different continents. have different cultures and different health systems, although they all have a primary care health system. But they have common problems. Often the primary care system is relatively fragmented. As I mentioned, COPD is heavily underdiagnosed and the treatment pathway is really lacking. In many cases, people could not afford the medications, or primary care was not able to prescribe any medications, and there was limited availability overall. So this is just a sort of high-level overview of research that we did. So in Brazil and China, we did large test accuracy studies to identify the most cost-effective screening strategies for identifying undiagnosed COPD. I think between 2,000 and 3,000 patients were screened in both of those countries. In Georgia, we did a pulmonary rehabilitation study. So we tested the feasibility of a culturally adapted pulmonary rehabilitation study. This is the most effective intervention for patients with COPD, but there's really low provision and low uptake because it's hard to get patients to get involved in increasing their exercise and their activity levels. And then in North Macedonia, where they have very high smoking rates, and in fact, smoking is really fun. They manufacture cigarettes, and therefore smoking is a really important part of the economy. We did a smoking cessation trial in North Macedonia in primary care. And finally, we did some extra exploratory work looking at physical activity in Brazil. So patients, COPD patients with anxiety and depression, and looking at how their views on physical activity, and then exploring the views of both patients and clinicians in China in the design of a new lung health service, because again, they did not have provision in a community setting. So if you want to, you can go and have a look at these studies. Most of them are all published now. This is the one from China, the test accuracy study in China. This is the one from Brazil, published in the Primary Care Respiratory Medicine Journal. And what we identified really was that a very simple set of questions and the use of the peak flow meter, so rather than any extensive spirometry, was a really cheap and cost-effective initial screening test for patients. So this could be done by anyone, in fact, because peak flow is not a difficult test to administer, and the questionnaire consisted of 10 to 12 questions, easy questions. In addition to those studies, a really important thing was that this program of work is really not just about the research, it's about developing people, developing researchers, and making an impact. So really being involved with important stakeholders. And our colleagues in each of these countries were able to engage with health ministries. Some of them were television personalities already, so they engaged with the media. And this all helped to influence policy change in various areas in the country, in each country. So our lead in Brazil was able to design a new COPD care pathway, which has been endorsed by the Ministry of Health and is part of what we're going to do next. In China, they had a big case finding program for COPD instigated, and so they were able to inform that. And in Georgia, they're trying to get their pulmonary rehabilitation program spread out across the whole of the country. And then finally, an interesting one in North Macedonia was that they felt that the smoking cessation trial didn't work. And it didn't work because people weren't, even doctors weren't thinking about stopping smoking. It wasn't a culturally normal thing. And so what they've done is they've decided that, more importantly, to embed smoking cessation education into the medical student curriculum. So they were able to impact respiratory health more widely in each of the countries. So this is our building on that work, this is now our program in South America. We're going to take the work that was done in Breathe Well 1, which was around the test accuracy studies and the identification of those cheap and easy tests. And in addition, the new COPD care pathway, and use that to explore how that might be best implemented in both Brazil and Argentina and Peru. So you've heard some of this before, but the reason why, so our NIHR funding is very committed to working with the most deprived people in the world. And of course, we recognize that in South America, you know, there are plenty of people who are well off, but there are also plenty of people who are very deprived. And it has really enormous inequity. And so our funder was very keen to work in South America. I've talked about some of these things. I think in the region, COPD is the 4th leading cause of death overall. And it's still in both, as well as Brazil, but in both Peru and Argentina, there is no particular COPD care pathway in primary care. And therefore, there is a great need to actually be able to identify all of these undiagnosed COPD patients and test whether identifying them and putting them onto a proper treatment program in the primary care setting would be worthwhile. And one of the important things is to have a really good implementation strategy, because we know that COPD, that primary care is different across the whole within each country and also between the countries. And so we are going to look at a strategy of task sharing and multidisciplinary teams in order to deliver this intervention. Our objectives are to develop the infrastructure, first of all. So an important thing is to make sure that here we are training people and developing the infrastructure so that we don't just do the one project, but we're able to so Professor Lotufo and his team is able to work with less experienced researchers and clinicians around the country and develop their expertise for the future. The second really important thing is that engaging with the most appropriate community leaders, clinical leaders, and policy stakeholders right from the start of the project, because if we don't do that, then any of the findings will not be taken up into practice. In the long term, it won't be sustainable. And the research objectives are, first of all, to assess the current quality of COPD care in primary care, develop some COPD quality indicators, co-develop and adapt new pathways of care which may be different in different settings, to identify and then manage COPD patients appropriately. We're going to undertake some feasibility studies to test how well it's implemented and to compare then across the different settings. And then finally, we'll be able to use a new health economic technique to model the preliminary cost effectiveness of this pathway, and its importantly, its potential impact on different segments of society. This is the management chart. Myself and Paymane, the co-lead with Peru, and Professor Lotufo, who's leading the the Brazilian team. Vilma Irazola, who's another famous epidemiologist, and she's leading the Argentinian team, and Antonio Bernabe Ortiz, and he's leading the Peruvian team. And these are other team members with different expertise, and we will have many collaborating institutes and cross-cutting committees in order to deliver this work. And importantly, for this kind of work, we also have an independent scientific and policy advisory group, hopefully with people from PAHO and important policy and clinical organizations, as well as a patient representative. And these are the hub. We're taking a hub and a spoke model. So here we have in Brazil, USP as the lead, what we call the hub institute, and then we have three other spoke institutes. There's the FMABC Medical School in San Bernardo, there's the Federal University of Maranhão, the Federal University of Amazon, and they will all work with their local primary care sites to do the research and build up networks and teams of researchers for the future. These are the work packages that I mentioned. So surrounding everything is the capacity building or the training and the stakeholder engagement, very central, and then our 3 work packages. So our first work package has these objectives, and I think because of the type of person that's here, I'll talk a little bit about the methodology on the next slide, so I won't go through that slide. So first of all, we're going to evaluate the governance and the policy context. And the way that we're going to do that is firstly, perhaps to so in each country, document health policy documents, review the health policy documents, and then conduct our in-depth interviews of around 25 to 30 national and local important policymakers who are leaders in the country in terms of influencing COPD care, particularly in the primary care setting. And these are the kind of frameworks that, actually those are the frameworks that we use throughout here, but I think the Schiffman and the Siddiqui frameworks are used in order to do this. Then we're going to assess the quality of care in terms of the processes and the foundations and the quality, and then we're going to map the coverage and completeness and the quality of our electronic healthcare records and assess any inequities. And the way that we'll do that is using as a benchmark the national or local guidelines on managing COPD, or international ones if we haven't got any local ones. We're going to do surveys of primary healthcare centres to find out, because some of this requires understanding what facilities are available, but we also need to understand people's opinions and knowledge about the topic as well. And so therefore we'll be doing surveys of healthcare professionals, so that may be GPs, but it may be nurses. These will be mainly primary care, and also 200 COPD patients that we need to identify, probably through primary care, but maybe other sources, because we'll also be asking about their experiences of care and their opinions. We may supplement this with nationally available survey data, but as we were discussing earlier, there's very little on COPD in the national data. And finally, we may use electronic healthcare data, but actually that's maybe not be very easily available or complete. We'll also be supplementing that with in-depth interviews and focus groups of the key stakeholders to understand the reasons and people's opinions and views on the quality of the COPD care. And finally, we'll integrate these findings to inform the remainder of the programme. In work packages 2 and 3, this is about co-developing and adapting the pathways to care. So we'll do this with a range of stakeholders attending our workshops. One-day workshops, we think, or this may be variable, and they will be taking aspects of the pathway and developing it and adapting it to their local setting and discussing what the implementation strategy should be. They will also come up with a core set of COPD indicators that we'll use for quality improvement. And finally, we will then be taking 6 to 8 primary healthcare centres per country and running through a whole intervention around screening and management and evaluating the outcomes with both quantitative and qualitative methodologies. And finally, we'll be using that information in this exploratory health economic models. And these are the analyses that we'll do and the frameworks that we will do to do that. Just got a couple more slides. Okay, so in terms of community and stakeholder engagement, this is an approach that we've outlined. So our teams will receive training and mentoring to develop protocols that are suitable for the country. But one important thing is to consider who it is that we want to identify and what will we do with those people. So we use this framework, which has got 7 key principles. Understand the context, which we'll have done from the first work package. Identifying the communities who are going to benefit. Identifying the relevant stakeholders. Deciding what it is that we want to achieve. And then thinking about the best ways to communicate to these different people, because it will be very different for different people. Patients will receive communications differently will need different type of communications from policymakers. And we tend to use this power times interest matrix to prioritize whether the person has influence and whether they're interested in the topic. And then that helps to decide if those are very powerful and also interested in the topic, they will be the key people that you want to identify. And with stakeholder engagement, we start from the beginning and we involve them all the way through the research cycle to ensure that the evidence is that the research question is correct and that the evidence is disseminated and taken up throughout and that the appropriate research is done. I mentioned also about the capacity building, and our model for capacity building is the individual, the institutional, and the environmental level. So at the individual level, people will learn how to deliver this research by a number of different methods, partly by training, but also by experience of delivering it and being mentored to do that. And we believe that it's a true partnership, so that there will be learning from countries in every direction, including ourselves. At the institutional and environmental level, we plan to develop clinical research networks of academics and clinicians, and potentially work with institutes to develop local centres of primary care excellence, and think about embedding more research into the medical curricula and other types of curriculum. And finally, we might think about working with funders or policymakers to think about long-term funding opportunities, particularly for primary care research. And this is something where people like Professor Lotufo will have those connections and those ideas. So we're learning from the people in the country as to who is best to approach. So finally, COPD is an important problem worldwide. It's heavily underdiagnosed, especially in lower and middle-income countries. It needs to be managed in primary care, and it needs a good pathway because there are lots of people out there and hospital care is not going to work for everyone. So our 4-year program in South America is in order to develop and evaluate the feasibility of this pathway. And we hope to come back to you in 2028 with the results. So I'll leave it there. Thank you very much.
Thank you, Rachel, for your terrific explanation. You are very grateful to be invited to join, to brief well, to resume our collaboration with the University of Birmingham. Now you have the moment open for questions and comments for the local audience and for the people who is watching. You have 33 people that can send by chat or personally by the video. Professor Isabella.
In our previous study about atrial fibrillation, we discovered that people were not using the primary care to treat and be followed by AF. They used the primary care units just to take the warfarin. And we discovered that most of the cases were in specialty healthcare outpatient clinics and tertiary care facilities. So my question is if we have a B plan if we found the same for COPD.
To be honest, I would expect to see the same because, as I understand it, most COPD patients or many COPD patients that know they have COPD are managed in the hospital setting. But that's just the tip of the iceberg. You know, there are all those patients out there in the community, some of whom presumably can't get to the hospital because it's inaccessible. They can't. So, and there won't be enough hospital doctors to treat them. So if we want to truly impact on the community, we have to go out and find those cases. So that's really the first part of the study, is identifying people with COPD that are not diagnosed. And the second part of the study is then bringing them to primary care and managing them in primary care, because there will be a larger volume if that was going to be a new approach.
Okay. Itamar.
Rachel, congratulations on our presentation. My question goes the same way. I think it's very related. How do you expect to screen the population there? Because I understand you want to know both those cases that are already diagnosed, and I agree with Isa. Most of these patients in the cities would be treated in hospital centers or specialized centers. And I expect you have a lot of people who didn't have the diagnosis before. And how do you expect to engage them in the study to participate in the pathway of care, in designing the pathway of care?
So the first question was around, what was the first one? Was the
how will you screen these people?
How are we going to screen them? Okay,
Yes.
yeah, and will we find the others? So we found that we were able in the previous study to identify, and we Sonia particularly identified people through a chronic disease clinic. I think it was the hypertension clinic, where people were coming into hypertension clinics. And of course, people with hypertension often have COPD. Well, it's a common risk factors. So that was the way that was done. I think in different settings, it may be different. And that's part of the project, is to identify which approach. So we could envisage, so they were able to bring people in, and we've decided that the simple peak flow and a questionnaire, but that could be done out in the community. So for example, in some settings, it might be suitable for a community health agent to be doing that. Other settings, it won't be. So the idea is to go out into the community, or to use the community hospitals to do that, or the primary care, the basic health units to do that. I agree with you about if we want to ask patients, it may well be a group of people. I'd envisage that we would ask COPD patients in primary care who are being managed in primary care what they think of their care, but it may be suitable, because a lot of them won't be there, it may be suitable to add in the extra group of those who are managed in hospital and alter the question slightly, so that we're asking them, well, why wouldn't you be managed in primary care? Could you possibly be managed in primary care? What are the barriers? So I think we could potentially modify that part of the research depending on the setting of each country and where the COPD patients are. But essentially, we're to go out there and screen them with a peak flow, and that should be able to be done by a number of different ways.
Thais.
In my opinion, here in São Paulo, we have differences between areas. Maybe some areas here in São Paulo, the family doctor couldn't ask one spirometry. So in these areas, these doctors should transfer the care to the pneumologist. So the same with the smoking cessation medicines. Some areas here in São Paulo, we could prescribe as family doctor the smoke cessation medicines, but we know that some areas they couldn't, so they need to references to the pneumologists. So it will be a barrier, mainly because I believe in all over parts of Brazil, they are very different. And in other countries, even I talked to Sophia, and in Peru, they don't have medications given by the government. So it will be, because we could do as warfarin. We could go to the pharmacies, the community-based unit pharmacies, and know, oh, please, could you give me the schedule of everybody that uses LABA, LAMA, whatever, or smoking cessations medicines, so we can find the patients that lives in this area and ask to community agents to see these patients, maybe, if the doctors don't know. But I don't have idea how to do this in another country where they don't receive the medications anywhere, and we could get these files.
You're right. I think it's very reliant on finding out, and that's part of the research, is to explore with different important stakeholders what it is going to work in those settings. That's the interesting part about it, I think. What can we do?
Guys, can I ask a follow-up question? Sorry, I just wondered, what is the reason that in some places the primary care cannot provide? Okay, so that's something we would find out. Okay, because it's not. Is it because the doctors don't want to, or they're not allowed? The government doesn't. It's not allowed. Okay.
So our recommendation at the end of the project might be, actually, maybe we've demonstrated it in some areas, and in these areas where the policy doesn't allow, maybe there's some policy change required.
Can I make another question, Rachel? I don't know if it would be to you or Professor Lotufo, Professor Isabella, but how do you expect to find no cigarette smoking patterns in these regions? Do you have an idea? Because I have some previous idea that it would have a pattern of smoking with non-industrialized tobacco and homemade cigarettes, but I don't know today with the electronic cigarettes as well, how it's in these regions. Do you have any information about that?
So the question was
Yes, the pattern of smoking in these centers, because for decades ago, non-industrialized cigarettes, so homemade cigarettes, here we call fumo de corda.
Yeah. Okay.
And how do you expect that? And if electronic cigarettes have been widespread there too, as in urban centers?
So I think the questionnaire that we'll use will not rely just on smoking. We'll be asking a whole range of other things, and they're specifically designed to be used for smokers or non-smokers who might have been exposed to other exposures. In terms of the electronic cigarettes, I don't know how that's captured I don't think it's captured in any of the questionnaires, but then I would imagine, because electronic cigarettes is really very recent, those people won't have COPD yet because they'll be younger and they won't have developed it. So at the moment, that's not a main issue. In terms of understanding the prevalence rates, I think we'll rely on local data for that, but that's not the main purpose of the study, to actually document the smoking rates. So I think it will be okay. We'll have a feel for what's out there, and the questionnaire should pick up the non-smoking COPD as well.
Rachel, considering the trial that you had performed, the usual care what's the comparison of the usual care before and after the trial? Because some trials, Mr. Fit 30 years ago in the US was very interesting, because the usual care was better after the trial than before.
So the practices that were taking part in the study in the usual care arm didn't receive anything other than the fact that they were randomized, and the policy didn't change and the behavior didn't change. There was nothing. And we measured the rates of smoking, the rates of new cases it was only 1 year. So in the rates of new cases in diagnosed in that 1 year period were exactly as historical data was before. So there was no particular change in the usual care arm. So anything that we spotted, I mean, it was fairly obvious that if you put something systematic in place, you're going to see a dramatic improvement, which we did. The important thing for us was more about which way was the most effective to identify cases. And we found that going direct to the patient was more effective than involving the GP, to be honest.
Because, well, one point is this open trial is the contamination with the usual care. So the cluster community trials is designed to avoid this. The personal considering the aspects of the primary care unit and the person. I think that's more possible to identify this. But my opinion, it is very difficult to see this because
we tried to look at the contamination, and we felt that, first of all, because of the design and because of the nature of the intervention, it would be very unlikely there was any contamination, because the usual care practices didn't have any instruction about what to do. They had no questionnaires. They just did everything as usual.
But so, the GPs that was in usual care, they are they knew about the trial or not?
They did, but I don't think they did anything differently.
No?
No.
Okay.
They weren't motivated to do anything differently, so they carried on as usual. And also, actually, the way that we did it was very facilitated by our research assistants, Paulo. So the GPs didn't actually do very much. It was mainly done by the research assistants and also the secretaries who gave out questionnaires when patients asked. Sometimes the GPs did something, but mostly it was other members of staff.
Okay. Another thing that, respect to the trial, is I think it is very difficult to see the aspects related to ischemic heart disease and other cardiovascular diseases that are very common among the COPD patients, because maybe it can define the outcomes because it's much more strong when you are considering death, of course, and semi-hospitalization.
Yeah, so in that trial, when we did the longer term follow-up, we looked at respiratory admission, where we thought we would have a much tighter effect, and all-cause admission, which would have been diluted by other different kinds of events, and death, which would have been diluted by the different kinds of events. I think that's a problem, but we powered it. Well, we looked at the power, and there should have been enough power to see some change in the respiratory admissions, and the other ones would have been difficult to see between the two arms, even more difficult, I think. But the main reason we didn't see a difference, I believe, or at least one main reason, was because we found them, but then they weren't managed any differently anyway. So that was one contributing factor.
Oi? Tem mais alguma? Bom, quem estiver à distância, por favor, coloque no chat ou apresente. E podemos ver aqui se temos mais alguém que gostaria de fazer algum comentário. Isabela, Thaís, Tamar já fizeram. Então, podemos então. Rachel, we are very happy to see you here. It was a nice presentation. And as you said, you have more 4 years together. You'll be working for more 4 years. Thais is here, Ana, Angelita, working directly in the Brifu too. And for us, it's a pride to resume the contact with the University of Birmingham. And the most important thing for us here is that we're spreading this knowledge to 2 regions of Brazil in the north, Manaus and Alcântara and Maranhão. I think for us it's very, very important to put more collaboration in these areas of our country. Thank you very much.
Thank you.